So let's talk about acute pelvic pain. So basically that'll be ovarian issues in girls and testicular issues in boys. Not surprising, ultrasound really is the most useful modality for pediatric gynecologic imaging. Most of the time we're doing transabdominal images, so you need a full urinary bladder, whether you do that with oral hydration, IV hydration, or putting a Foley catheter and retrograde filling. Depends upon how soon the information is needed and how well your patient can tolerate having a full bladder. Don't forget to do transvaginal scanning. If the girl is sexually active, if she uses tampons, this is a viable alternative. It's well tolerated and it can certainly save you time by not having any bladder preparation. The most common thing we see are just simple ovarian follicular cysts, that these can cause pain. In this particular child, there's a large left dominant follicle. This may have a little bit of internal hemorrhage within it. These things certainly can cause pain, especially when they rupture. My favorite case here is this child who was in our department. We were doing an ultrasound. She was having pain that was in fact localized to the side with the dominant follicle. As the sonographer came out to show the images to us, there was a cry of pain from the room. We went back in and rescanned, and now there was all of this free fluid within the cul-de-sac, which was not there before, and this child ruptured her cysts right in the middle of our exam room. So even though it's a small cyst, certainly cyst rupture can cause a very large amount of fluid, probably from the cyst and some subsequent hemorrhage. So look for that. These are the most common causes of pain. The thing that the emergency department is usually most worried about is ovarian torsion. And these are most common in the younger child, around puberty and young adulthood. Acute onset of symptoms like with testicular torsion. Many of these girls will have a palpable mass. Many of them will have had prior episodes of twisting and pain. And certainly if you have a large cyst or a tumor, that can predispose to ovarian torsion. This is a in utero torsion. A child with a cystic mass seen in utero was born, and we see this complex fluid-filled cyst with a debris fluid level. And down at the bottom there was this kind of swirling pattern down toward a central pedicle at the base of this mass. And at surgery, I think you can see here is the pedicle, the torsed necrotic ovary, and we were seeing this sort of swirling of the base as it came down into this twist. So that's been described. I haven't seen this frequently, but again, it's something you can look for to help narrow your diagnosis when you're doing scans in these kids. The most reliable sign for a torsed ovary is a large ovary, and several good papers have come out recently showing that ovaries are typically 4 times or 10 times the size of the contralateral ovary. The classic is a large ovary with peripheral cysts, thought to be fluid pushed into nascent follicles. Often you'll have some cul-de-sac fluid. That's clearly not specific. And again, while we Doppler these ovaries looking for flow, do not be dissuaded if you are able to pick up some arterial flow because of the dual supply from the ovarian and uterine circulations. Even if you have a torsed ovary, you may still be able to get demonstrable arterial flow. So here's a classic case in a teenage girl with acute pain. We have a very large ovary with peripheral follicles, and here's the normal ovary for comparison. Certainly this thing is grossly enlarged and not much doubt about the diagnosis. This child also had acute pain, had a rather complex looking ovary, maybe some peripheral follicles. We did not see any calcification or fatty mass. This kind of looks like a fimbriated end of a fallopian tube to me. And here's a laparoscopic picture showing the uterus down here with the broad ligaments. Here is the torsed fallopian tube, and here is a large torsed necrotic cystic teratoma in this young girl. You have to have a high clinical suspicion. If you have an ovary like this, you may not be able to have a specific diagnosis, but if you're going to have any hope of salvage, the surgeons have to be willing to go in and you have to be willing to raise the diagnosis. Classically, the salvage rate has been very poor, roughly on the order of 10%. In the era of laparoscopy and a little more aggressive surgical treatment, at least at our institutions, the salvage rate is probably just above 50% right now. Another problem is that since these are intra-abdominal, they can have rather a delayed presentation because of what are felt to be non-specific symptoms that are often attributed to GI tract disease. For the acute scrotum, the number one concern is testicular torsion. And the classic mantra is that if you think it's torsion, the child should go directly to the operating room without going to any sort of imaging. And the reason for that is that if you're going to salvage the testes, you have to get to them early. So this classic paper showing that if you operate over 12 hours from the onset of symptoms, the odds of salvaging the testicle drop rapidly, and over 24 hours the salvage rate is essentially nil. And so while testicular torsion is a clinical diagnosis, it's clear from the literature and experience that most children that present with acute scrotal pain actually don't have it. The exam can be unclear in those that do have it, and it can be a very litigious area, at least in the United States. And all of that put together means that imaging becomes very important in the diagnosis. Ultrasound with Doppler is the standard. Very few places use nuclear medicine anymore. Grayscale, color Doppler, or power Doppler, and you have to find a waveform. You have to prove that there's arterial flow to the testicle. Now, while the grayscale is said to be unreliable for torsion, there are very few cases, in fact I can't think of any, where there's been testicular torsion and the grayscale has been completely normal. So we'll go through a few of these findings of transverse lie, twisted spermatic cord, bell clapper deformity, and paratesticular mass. So in this case of torsion, we can see flow in the normal right testis and no flow in the torsed left testis, but look at the labels. So these are long relative to the scrotum, and on the right, the normal side, the testis has a longitudinal view, as you would expect. However, when you're looking at the torsed left testis, while the probe may be longitudinal, we really get more of a transverse view of the testis, and that's because as it torses and twists and rises, it rotates, and so it has an abnormal lie within the scrotal sac. You can also see there's some thickening of the scrotal skin, a reactive hydrocele, and while they are not specific for torsion, certainly it is another indicator that there is some abnormal process going on. Looking at the spermatic cord itself is being increasingly recognized as a very sensitive way of diagnosing torsion. So in this particular child, certainly we have an enlarged hypoechoic testis, flow in the normal side, no flow in the painful side, but I think you can look at this and kind of imagine this sort of undulating course of the cord, and when you put color on, there's flow in the cord all the way down right to the testicle and then no flow whatsoever. In this case here, I think you can get a better appreciation of the twist of the spermatic cord as it comes down, and again you can see flow within the spermatic cord all the way down to the testicle, which has no significant perfusion. This is a clip loaned to me by Gloria del Pozo from Madrid, and I think as she's scanning transversely up and down the cord, I think you can get an appreciation that there's sort of a whirlpool sign, just like we saw in midgut volvulus. As you move up and down the cord, you can see that these vessels wrap around the central part of the cord, indicating that you've got a twist. Testes torse because they are not normally fixed to the scrotal wall, and so the term is a bell clapper deformity, where the testicle hangs within the scrotum like the clapper within a bell. And this can be a difficult diagnosis, but if you do have hydrocele fluid and you scan very gently, you can probably demonstrate, as in this case, that there is fluid all the way around the testicle, that it is not attached in any way to the scrotal wall, and the only thing that it is attached to is up here where the cord comes in. Now, this child had acute scrotal pain. He's got an enlarged testis compared to the other side, but right now he doesn't hurt, and that's a key thing that we'll get into. His pain is better. He does have flow. He doesn't have a problem right now, but this is abnormal. This child has abnormal fixation, and while he may not need an operation now, he certainly needs to go see the urologist to get PEXed, and he also needs to be aware, as does the family, that if he has recurrent pain, he has to come right back, because he is a setup for recurrent torsion. This paratesticular mass has also been described. Here's the testicle. Here is this abnormal, almost equally large soft tissue mass within the scrotum, and this is going to be composed of the twisted cord, the swollen epididymis. Again, color Doppler is our key. Flow in the asymptomatic normal side, no flow in the symptomatic torsed side. Again, color Doppler, this is your key, okay? This child has an enlarged testis, becoming a little heterogeneous. You start to worry about viability when you start getting grayscale changes. Here's another case. And then lastly, when you get testes that look like this, There is complete infarction. You may have areas of hemorrhage. Lots of hyperemia around it. This would be the Doppler equivalent of the nuclear medicine donut sign, with hyperemia around this testis, cold, no flow in the center. And once you see this, these kids do not have salvageable testes.